chapter 5 today, and it's really an introduction to chapter 6. Kind of strange the way the book is organized. So we're going to talk about the structures, the typical surface anatomy, how you name bones, and then get into the actual bone. The actual bones that are in the body. Okay, so we have structures that are called long bones. They don't have to be that long. As long as they are longer than they are wide, they're in the category of long bones. If you look at your fingers, all these little phalanges, they're longer than they are wide, so they're considered long bones. Radius and ulna, obviously long bones. Humerus, femur, tibia, fibula. But even down there in your toes, your phalanges in your toes, they're longer than they are wide, so they're considered long bones. When we get to short bones are going to be about squarish in shape. They may have a little bit, they may be a trapezoid shape, they may be triangular shape, but they're not irregular enough, they're not having weird enough shapes to be in an irregular bone shape. You look at the vertebrae, it's got an arch on the back and it's got processes going out to transverse and straight back to spinous. It's got a body in the front. Or you look at the sphenoid bone and it's got wings everywhere. Those are irregular. They're very different shapes. A short bone will be your wrist bone, your ankle bones. Flat bones will have some bones that have parts of them that are flat, but if the rest of them is very irregular, they get stuck into the irregular category. For example, your scapula, very flat, but then it's got I'm going to say olecranon, that's wrong. A chromium process and a coracoid process and a spine, so it's irregular. We've got the temporal bone that is flat, but then it has this long process that comes forward, so it's stuck in a regular bone category. So flat bones of the skull that don't have anything extraordinary happening with them, so frontal, parietal, occipital would be considered flat. Your sternum is a flat bone, your ribs are a flat bone. Sesamoid bones, by definition, they are developing in a tendon. That is your anatomical definition. Don't care what KRS says, these are bones that develop in tendons. You actually have an x-ray in your textbook where they're showing you a baby that has osteomalacia. You look at the little baby, doesn't have a knee yet because the knee is non-weight bearing. So when you use a joint a lot, a sesamoid bone develops. Patella develops in a tendon. Sutural bones, also known as Wormian bones. This is an eponym, but it's still in the textbook, so just be familiar with it. If I ask you to find a sutural bone, you, number one, look only at the skull because that's the only place you're going to find sutures. And then you look in the suture. If you see a bone in the suture, that's a sutural bone. So it could be the size of a grain of sand, or it could be as big as a quarter or a $50. So they vary in size. So example of a Wormian bone or a sutural bone. You look in the sutures, and here's one that's about the size of a quarter. What happened there was before the skull had finished growing, and you had the final joining of the bones together. There was cartilage in the area where the sutures are going to form. And if some cartilage dies in the center, then you get some ossification occurring from the center, still surrounded by cartilage, and the sutures are forming outside. So you get bone developing in cartilage. Eventually that cartilage is all ossified, and now you've got a bone surrounded by the sutures. So they call it a sutural bone. Irregular bones, they're going all different directions, all different shapes. Vertebra, that's a regular bone. Sphenoid bone in the skull, that's irregular. Your scapula would be an irregular bone. So there's a lot of different examples. Long bones, obviously humerus, but also your metacarpals and your phalanges. Those will be long bones. Wrists, so carpal bones and tarsal bones will be short bones. Patella is the largest sesamoid bone in your body, but it is a sesamoid bone. So phalanges, metacarpals, metatarsals, all of those are long bones. Flat bones have the flat shape. You look at them from the side. Parietal bone is an example, also frontal and occipital bone. So occipital bone, most of it is flat, and frontal bone also flat. Inside the flat bones, you don't have a marrow cavity, but you have trabecular bone and you also have cortical bone. So it looks identical to any other bone in the body, but just no marrow cavity. The spongy bone has a special name called diploid. A lot of different superficial markings on the bone. Some of them are there because they formed during the ossification process. The head of the femur, the neck of the femur, the greater and the lesser trochanters, they're all secondary ossification centers. So whether or not a muscle is pulling on them or you have weight bearing on that part of the bone, those structures will be there from the time the ossification process begins. But something like a tubercle or a tuberosity are there because muscle is contracting and then pulling on the surface of the bone where the insertion or the origin of the muscle is. So that force that's applied to the bone will create a tuberosity, will create a tubercle. Tuberosities tend to be bigger. They tend to be rougher than a tubercle. Tubercles tend to be rounder and smaller, but not always. So there are some classification characteristics that you have to be clear on. Sometimes it's obvious. If it's big and rough, it's going to be a tuberosity. But sometimes tubercles can be kind of rough in appearance as well. I understand that Dr. Prince, he doesn't care whether you call something a tuberosity or a tubercle. I care. In anatomy, you care. In kinesiology, it's an elevation on a bone due to muscle forces applied to it. You don't have to care in kinesiology. In anatomy, you care. So up here, you have to know your tuberosities from your tubercles. Okay, so here's a round tubercle, something that's not too round, also considered a tubercle. Next can be obvious that there's a head here and a neck there. Here the head is kind of flat. And you've got a neck that looks like the shoulders are all hunched up. You can't really see a neck. And what they're labeling here as a neck is actually the surgical neck. So in the humerus, you've got two necks. You've got the head, that's your articular surface, nice and flat. And then where it indents a little bit, that's your anatomical neck. And then where it comes together and goes down to the shaft, that's your surgical neck. So you're going to actually see it correctly labeled in the bone chapter in chapter 7 in appendicular skeleton. They'll talk about the surgical neck and then label up here the anatomical neck. Surgical neck means that the surgeon who's doing a joint replacement, he's not going to bother just trying to get in there and removing the head and neck region and putting a prosthesis there. He's going to whack off the whole end of the bone and then replace the whole end of the bone. And so he'll take this whole end off and put a prosthesis in place of it. So shaft of the bone, where muscles attach and pull on the shaft, you have a tuberosity. Where muscles pull on the end of the femur, you get a tubercle. And here, the proximal end or the distal end, we've got two tubercles labeled. A smooth surface that something can move on is called a facet. And then there's also beyond on the back side or the underside and then to the back side of the femur, there will be condyles. So this facet is where the patella is going to move. And then underneath that, continuing from the facet on that, there will be two condyles, the medial and the lateral condyle. This whole surface on the distal end of the humerus is a condyle, but it's broken down into a hinge portion. If you look up trochlea, trochlea means hinge. In this case, it's a bony hinge that will form with the ulna. And then lateral to it, the rest of the surface will form a joint with the radius. So we're going to learn that that part is called the capitulum of the condyle, and the medial part will be the trochlea of the condyle. A fossa is a scooped out appearing structure on a bone. Fossas can be small or fossas can be very big. So they look like something got in there and with a spoon and kind of scooped out some of the bone, then they'll usually call that a fossa. The fossas can be because a bone needs to fit in that space when it has moved into a certain position. In the front of the humerus, you have a small fossa when you have your forearm flexed. And then the ulna will go into a big fossa on the back of the humerus when your arm goes into extension. So these will be relatively smaller. This will be bigger. What's sitting here in that fossa is all nice organs that are relatively smooth and can take the shape of whatever structure is there. So you don't want something here that's too roughened up. You want a nice smooth surface, kind of cups the organs that are in the abdominal and upper pelvic region. So trochanters, secondary ossification centers. Tubercles are there because the muscle pulled on the bone. A tuberosity is there because muscle pulled on the bone. If the muscle pulling on the bone enlarges it so that it has a pointed end to it, then you call it a spine. We've got spines, one spine, two spine, another here, and two more on this side. Well, we're going to have spines, and we're going to describe them for their position. They're going to be anterior and posterior spines. There's going to be superior and inferior spines. If they're all on the same bone, you have to be very specific. You have to say anterior, superior, name the bone, and then call it a spine. So that spine is anterior superior iliac spine. That spine is the anterior inferior iliac spine. If there is only anterior, you don't mention anterior. If you say anterior, then that tells you there's posterior. If you say superior, that tells you there's an inferior. The fact that we have an anterior superior iliac spine tells you there's going to be a posterior superior iliac spine and a posterior inferior iliac spine. So you're going to learn all those when we get to appendicular skeleton. That spine, however, isn't on the ilium at all. It's on the ischium, and there's only one spine there, so all you have to say is ischial spine or spine of the ischium, and that's finished naming it. A crest is where there's a broad attachment of a muscle. When the muscle pulls on the broad attachment, it elevates everywhere. If it's pulling in a particular direction, it can cause a little bit more elevation, and if it looks like a wave cresting, they call it a crest. So here's a crest on the ilium. The term foramen, we have foramen in the skull, and we have the biggest foramen in the occipital bone called the foramen magnum. We've got large foramen here, but they're really not foramen at all. There's connective tissue there and no space to speak of. Some things go through the connective tissue, but after the connective tissue is removed, then you've got a foramen. We've got small little foramen below the eyes. We've got small little foramen above the eye. Foramen can be any size. Can be as big as a foramen magnum or as small as just barely getting a broom straw through. Some holes that look like they could be called foramen will be called a meatus. So, or a canal. You just got to kind of relax and go with it. Sometimes they're called meatuses and sometimes they're called canals, but they're still looking like they could be a foramen. Foramens develop generally because there was something there before the bone formed. A lot of times it's a nerve. Sometimes it's nerves and blood vessels. If it's a lot of nerves and blood vessels that are taking up so much space, the bone forms around it and you get a jagged, irregular opening in the bone, we call it a fissure. So a jagged opening in the ground, you call it a fissure. Jagged opening in the bone, you call it a fissure. A ramus is a term that can be used in tissues, it can be used in the bone. So nervous tissue, you'll have ramuses, and in bone, you have a ramus. It generally is a more or less straight piece of bone connecting some other identified feature to another identified feature. So in the mandible, we have an angle of the mandible that's defined, and then we have a piece of bone that connects it to two processes that are specifically named. So this connecting piece is the ramus of the mandible. So we've got a canal here, and we've got a meatus. Those are openings in the bones. We have areas where there are just large dilated areas in the bone that will contain respiratory epithelium. They're there to drain into the nasal cavity and serve to trap particles that may be inhaled. They also lighten the weight of the skull, so you're not having your scrawny little neck muscles having to hold up so much weight. So they lighten the skull, but they also are serving the nasal cavity and putting mucus out into the nasal cavity. So those are referred to as sinuses. But a sinus can be a dilated area in the bone, be a dilated area in capillaries, can be dilated areas in veins. So the term sinus is just meaning it's a dilated area in a particular structure. So when we get into blood vessels, when we get into the endocrine system, you're going to see that term sinus applied to something besides the bone. So just remember it's a descriptive term, meaning there's a dilated area there. So this good summary to look at. So elevations and projections. You can have a process. So it might be an articular process. It might be a transverse process. It's anything that is going in a particular direction. A ramus is usually connecting two things together. So we had the angle of the mandible connecting to the articular processes of the mandible and muscular process for the mandible, and that was connected by a ramus. Trochanters, this is the largest process because it is a secondary ossification center. Will always be there whether muscles are working or not. We have a person born totally paralyzed. They will always have a trochanter and will always be there. But a tuberosity or a tubercle will not be there if muscles do not pull on the bone. Tuberosities tend to be rough, and tubercles tend to be more rounded and a little smoother. A crest, a line, or a spine, those are also due to tendons and ligaments pulling on the bone. Crest is kind of a ridge, so there's a broad attachment of the muscle. A line is also a ridge, but it looks like a line. So we're going to have temporal line, and it looks like an arched line on your parietal bone. It's got a muscle that's attaching there, and every time you chew, that muscle pulls on the parietal bone and creates the line there. Got a line running up the back of your femur. Every time you extend your knee, the quadriceps, of the quadriceps pull on the back of your femur, create a line there. A spine, I went over the spines with you, the anterior superior iliac spine, posterior inferior iliac spine, ischial spine, kind of boring, kind of the only one there. But if it's a pointed process that's due to muscles pulling on it, then you call it a spine. Heads are round or relatively round surfaces. Head of the humerus isn't really round, but it's got a rounded surface. The head of the femur is nice and round. The Neck region can be an obvious indentation, like your neck, or it could be a squatty little region, like on the humerus. Condyles are smooth, and trochleus can be, they're also a condyle, but they're a specific type that is for a hinge joint participating in a pulley system. A facet is a flat surface for bone-to-bone movement. So the example on the previous slide was the facet for your patella. Depressions can be scooped out, so shallow depressions, relatively shallow in appearance. So the fossa, a little bit deeper and narrower, can be a sulcus. Sulcuses tend to be where blood vessels or nerves were there first, and then the bone formed around them, so you get an elongated groove. So foramens or meatuses or canals, those are where bone formed around some structure that was already there, like blood vessels or nerves. A fissure is a big opening because a lot of nerves, a lot of blood vessels were all lined up in a row before the bone formed. So they took up the space, bone formed around them, and now you have an irregular, kind of jagged opening in the bone. Sinus or antrum, hollowed out or dilated area of bone. So look at these because we're going to be running through the articular, the bones of first your axial skeleton and then your appendicular skeleton. We're going to be using these terms, and you got to be up to speed with them. I'm not going to teach them to you. Actually, you're supposed to come and already know all of this. Technically, I don't even have to refer to any of this. I just have to review the bones with you. But I know some of you don't remember. Some of you have come in without any previous experience in anatomy and physiology. So we're going to go over them. By the way, your next exam is next week, Monday. I just realized that myself today, so I'm going to be working on your exam, and you're going to be studying for your exam this week and this weekend. So axial skeleton. We're not going to talk about clavicle, scapula, upper extremity, or your pelvic girdle or lower extremity. So it's your head, your spinal column, your vertebrae, and all the way down to your coccyx, so your vertebral column, and the ribs and the sternum. That's your axial skeleton. Function of axial skeleton is protection. We have an exoskeleton here that protects our brain. Got the vertebral column that protects the spinal cord and some of the extensions of the spinal cord, the nerves that exit down below. And then we have our ribs that protect the nerves and the blood vessels that are coming out and around to the front of our torso. And those will connect to the sternum if they're a true rib by their own cartilage. If they're a false rib, by a cartilage that fuses with a true rib's cartilage. And we have two ribs that are considered floating, that are attached to a vertebral column, but not attached to the sternum. So the ribs are there to protect your lungs and your heart and your major blood vessels. Your vertebral column doesn't provide much protection for the abdominal organs. The rest of the protection that's bony is part of your appendicular skeleton. So your stomach and your colon and your small intestine and your bladder and your ureters and your uterus in the female, those are not protected by the exoskeleton. They'll be partially stabilized and supported by the appendicular skeleton. That's in chapter 7. Up in your head, you've got very special sensory receptors. You've got your eye. You've got to protect the eye, but you still got to have an opening so photons of light can come in. Got taste buds here. Got olfactory epithelium up your nose. The hearing and balance mechanisms are in the inner ear in a very hard rock-like structure. Channel out that hard rock bone and put delicate membranes in there. Then you have your hearing and your balance apparatus. Has a summary here. Everything in yellow for this chapter is exoskeleton. So bones of the skull, we've got cranial bones and facial bones. Facial bones are the ones where facial muscles are attached. Cranial bones are the ones that are around the brain. In the bones of your cranium, you also have your auditory ossicles. 3 really itty-bitty tiny bones in your middle ear that serve to amplify sounds that are coming in through your external auditory meatus. Then we have one bone that kind of anchors your tongue and then connects shoulder and neck muscles to it to stabilize the tongue, and also the neck region helps with some movement of the neck. So that's your hyoid bone. Thoracic cage, one sternum, but it could be more than one bone, because if you don't get complete ossification of the individual bones that make up the sternum, then you'll have more than one bone to identify. The sternum is actually made up of that triangular portion there, that's the manubrium, and then 4 to 5 pieces of bone that fuse to form the plate of the sternum. The vertebrae, you have 24 movable or relative, sort of movable vertebrae from your cervical down to your lumbar. And then you have 5 that are fused to form the sacrum, and then various numbers that fuse to form a coccyx. So if you get complete ossification, you have 1 coccyx, you have 1 sacrum, and then 24 movable vertebrae above that. They're all uniquely identifiable from each other. The cervical region, the job of the cervical vertebrae are to protect the vertebral blood vessels that are going up the back of your neck. So the bone will form around those blood vessels, the vertebral artery and vein. So in the transverse process, there will be a hole. There's a ligament, elastic ligament, that runs up the back of your neck, and the bone will form around that and attach that ligament to the vertebrae. So the spinous process will have a fork appearance, bifid spinous process. 2 ways to tell a cervical vertebrae. Thoracic vertebrae will have attachments for the ribs on their lateral processes or transverse process, and also on the body of the vertebrae. So those costal facets will be an indication of a thoracic vertebrae. And then your lumbar will not have a transverse foramen. They will not have costal processes, and their spinous process will go more or less straight out and look kind of square-ish. So there are ways to distinguish those vertebrae from each other. Facial bones, well, first let's do the cranial bones. So frontal, you usually have one frontal bone, but we're going to see on a later slide that it actually develops from two. You get a complete fusion of the two pieces together and absolutely no indication that there were two bones to start with. That's what most of the time you see. But it actually forms from two. Parietal formed from two units. Temporal is going to form from several types of ossification. Occipital, several types of ossification. The temporal bone is a complex bone. It has this process. It's got that process. It's got an opening in it. It's got another process. It has a flat part, but that is the minority of the bone. So this is an irregular bone. These others would be considered flat bones. The sphenoid bone has two processes that go straight down. It also has multiple things going on that are going from one temple to the other, and it's spanning that space in there. So we're going to see when we look at the inside of the skull that there's multiple things going on with the sphenoid bone. So it's going to be irregular bone. Ethmoid bone, what you see there is just the perpendicular plate of the ethmoid bone. You don't see the air sinuses. You don't see the nasal concha there. You don't see the little openings for nerves that go from your brain down into the top of your nasal cavity. So that too is going to be an irregular bone. So to sum up the cranium, 8 bones. 14 bones each side of your face is going to have a zygomatic bone. It's going to have a nasal bone, maxillary bone, and mandibular bone. The vomer, there's only one vomer. There technically is only one mandible. The zygomatic bone, they're paired on either side, so 2 of them. 2 little tiny bones that are there to channel your tears into your nasal cavity. Those are your lacrimal bones. 2 nasal bones. 2 palatine bones that you don't see. They join the maxilla. The maxilla forms part of your hard palate, and the back part of your hard palate is formed by the palatine bones. The palatine bones work their way through your nasal cavity and end up in the floor of your orbit, the tiny little piece in the floor of your orbit. So they're going to form part of your top of your mouth, part of the lateral walls of your nasal cavity, and part of the lower orbital surface. 2 maxilla. So sum it all up, and you've got 14 bones that are working with the in the facial region. You look at the skull from the back. The occipital bone has multiple muscles and tendons attaching to it, also elastic ligaments attaching to them. And so when you use your neck and muscles, you get elevations and protrusions on the occipital bone. The external occipital protuberance, if you see the term external, what does it tell you? There's going to be an internal. So don't mention external unless there's an internal. If there was only an external, then all you'd say was occipital protuberance. So if there's only an internal and no external, just call it occipital protuberance. You stick that term there, that means you got to look inside for internal occipital protuberance. Looking down from on top, you see the Greek letter lambda here. This is your lambdoidal suture. Doesn't really include the sagittal suture. this part is the lambdoidal suture, and then this is your sagittal suture. The lambdoidal suture is formed by your parietal bones and your occipital bone. Sagittal suture by your two parietal bones. The squamous suture that you see here, you come back to the temporal bone, the flat part of the temporal bone and the parietal bone are forming that squamous suture. So frontal bone, looking at it from above, no indication there were two bones to begin with. Nasal bones, two that you can see from above. You can also see these temporal lines due to the muscle, the temporalis muscle. Doesn't have anything to do with the temporal bone. This is a temporalis muscle that is contracting and pulling on the parietal bone to create these temporal lines. So inferior temporal line and up above, and a superior temporal line. We have a process coming off the zygomatic bone. We're gonna practice. Gotta check my time. Do I start this now or do I call a break? Okay, so take an early break because we're gonna practice how you name processes. I'm just gonna introduce it to you now, so during the break you can think about it. Number one, name the direction or bone the process is going toward. And then number two, you name the bone that has the process. If you know these rules, you can name any process in the head. So name the direction or the bone that it's going towards, and then name the bone that it's coming from. Okay, so think about that, and then we'll practice after the break.